Hey everybody, my name is Isaiah, and the agency that I am working with, or doing my field work through, is the Stabilization and Crisis Unit. It is through the state of Oregon, and it's been around since 2000, and that's when they shifted over from Fairview, which was in Salem, and that was Oregon's version of an institution, and they switched over after shutting Fairview down in 2000 and made these group homes for primarily adults that have intellectual and or developmental disability. And there's about 20 homes all up and down the I-5 corridor, all the way up from Portland down to Eugene. And the goal of SACU is to help stabilize these individuals because they have IDD. Many of them also have co-occurring mental health issues, and they come into the agency in crisis and they need stabilization. And because the general public doesn't have the resources available to help them out, they come to SACU. SACU's goal is to stabilize, give them resources, goals, and then back out into the community. Usually that's in the form of a private group home, so kind of stepping down from restrictions and where they have a lot more involvement with a team that's very microscopically looking at their behaviors and stuff like that. So that's kind of the goal. Their main source of, well, the only source is through Oregon payers' tax dollars, and SACU is through the tax dollars. There is a crisis outreach and assessment team that's called COAT. That is who I am shadowing with the psychiatric workers, and they have a separate funding account, and we'll touch more on that a little bit later, but just kind of a brief overview. If SACU were to dissolve, COAT would still potentially exist in an expanded form, and there would be more of a budget allocated for the services that COAT provides. As for the laws and policies and practices, it's the ORS 427, and that basically is the rights of the individuals and kind of the services that they can expect to receive while they live in SACU or any private group home within Oregon. So basically they're a vulnerable population and they are heavily protected, and there's a lot of things that they are allowed to advocate for and things that cannot be done or said against them, which is good. In terms of the structure, like I said, there's about 20 homes up and down the I-5 corridor. The base level, and I'm sorry I don't have a model for this, but just it's pretty simple. Base model, floor staff. Each home has about 4 or 5 individuals that live there, which equates to about 15 to 20 floor staff that rotate on different schedules 24/7 that take care of them. There's also, each house has a manager, an assistant manager, IACP, I think, which is an individual care provider, as well as a QCBP. Don't remember what that stands for, but they're basically the behavioral specialist. And within, they're called islands, and so there's about 3 or 4 homes per island. Each island has an area manager that oversees all the other managers and assistant managers. The ICPs and the behavioral specialists are overseen by a clinical service manager, and kind of works its way up the hierarchy from there. In terms of leadership, Sierra Rawson is the director. It's not a huge agency, even though it is under the Department of Human Services, but it kind of breaks its way down from there. Brian Weir is the deputy director. There's a nurse manager. Each island does have a nurse that is responsible for making sure the individual's medications are up to date, advocating for primary doctors and whatnot, and working with pharmacies, working with the staff to make sure that they're all up to date with their training so they can appropriately pass meds, etc., etc. Winston Brown is the regional oversight manager, so he oversees all of the managers. And then Aaron Hall is that clinical service manager, like I said, who's overseeing the ICP and the Qs, as we call them. So pretty structured as it is through the state, so everything's got a hierarchy, kind of a breakdown of roles and responsibilities. Then there's COAT, like I mentioned, the Crisis Outreach and Assessment Team, and that is headed up by Alicia Apa, and the manager is Dan Foster. There are 9 PCCs who work together with 2 DSCS, direct support crisis specialists, and they are specifically usually floor staff who have now become COAT. That is what I used to do, and then now I'm in this shadow position with the PCCs. The PCC is a psychiatric crisis counselor whose goal is to advocate for the individuals and come up with resources, work with the team. The DSCSs, or the COAT people, specifically go deal with crisis. So anytime an individual has a behavior and the staff need extra support, the COAT members go in and help, kind of de-escalate, and then the PCCs are more on the proactive, the advocacy side of things. So I've kind of switched from more of a reactive role, and now I'm watching more of the proactive, figuring out how to advocate for the individuals. There's a north, central, and a south team, and there's a day swing and a weekend shift, and so there's a PCC in every single one of those roles, along with the appropriate COAT members. The state, I've kind of already touched on it, the objective for SACU is to stabilize and reintegrate these individuals, as well as hopefully develop and teach them some new skills. The COAT values are roughly the same, but also more of that proactive and reactive, building rapport, building that trust with the individuals, and helping reintegrate them back into the community. In terms of collaboration with the community, before I started working there a number of years back, and this was kind of coming out of Fairview, a lot of the individuals had kind of essentially part-time jobs and for very, very minimal amount of compensation financially, but they did tasks and were compensated for it, and that kind of got dissolved, and I'm not really sure why. There might be some of you who maybe know more about that, if it's also something that's happened in other states, but COVID really shut things down, and so now we're seeing kind of re-implementation of individuals getting more involved in the community, whether that's some of the, there are kids, primarily adults, but there are a few kids who they're back at school now, or there's some individuals who are trying to get those part-time jobs. There are some individuals who are trying to get their GED or maybe perhaps get an associate's degree. So there's a whole range of functionality, and some of the higher functioning individuals are pursuing different kind of roles and tasks. But mainly, and coming back to what I had mentioned earlier, COAT would be seen in this bigger role if SACU were to dissolve, or just if there was more funding that was provided to COAT and more positions available, to where potentially COAT would then go not only to SACU, but to other private group homes and check in with the individuals, do proactive visits, do reactive visits, and there would be more psychiatric crisis counselors who could advocate for the individuals. And then finally, the last point, the delivery methods. Mainly, SACU has been trial servicing for a few years now, CPS, which is the collaborative problem solving method, and that has been implemented from, I believe, the Massachusetts State Hospital, and SACU is now trying to use that, even though the functionality of the target audience is adolescents. They're trying to implement it and see how it works with both the adult and children population within SACU, and I think there is varying degrees of success. I know that when I've used it, it's similar to just strengths-based approach, but it's using what the individual has and allowing them to problem solve with you, and so it's just kind of this format of very similar to strengths-based, I guess. So it seems to be working, but I think because they're still assessing, that's to be determined. So that is the agency that I work with. If there's any questions, just please make sure to comment. Thanks for listening.